at this ASH meeting, there's been a plethora of data with regard to next generation sequencing and really picking apart the molecular architecture of myeloproliferative neoplasms and looking at what the implications might be for patients' prognosis, responses to treatment, and also outcomes, for example, after not drug therapy but transplantation. The large databases of both the Florence group from Alessandro Vannucchi and the Mayo group of Ayalew Tefferi have shown that a significant proportion of patients with polycythemia vera and ET may well have additional mutations that might perhaps impact upon prognosis, although further data is required to look at things like duration of disease and impact of therapies upon these mutations. It should help us in the future to understand more about what can happen in the disease course, what drugs might impact better which specific patients. And this is really a sort of watch this space type data. Interestingly, in one of the myeloproliferative neoplasms that we don't often have an update on, there are two groups reporting next generation sequencing data in patients with systemic mastocytosis, particularly in patients with this disease and an associated non-mast cell hematological malignancy, the commonest of which is usually CMML, for example. And so the group of Andreas Reiter and Animesh Pardanani, separately from the Mayo Clinic, have shown that patients with mastocytosis and an AHNMD have a worse prognosis if they have mutations affecting epigenetic machinery and the spliceosome, for example, ASXL1 mutations. So again, this is really further annotating our knowledge about this very difficult disease and highlighting patients for whom we may wish to move to more aggressive therapy, certainly for mastocytosis. And lastly, we've also seen increasing data now with regard to myelofribrosis and next generation sequencing. During the course of 2014 and 2015, it's become apparent that patients who have one or more of a group of mutations, particularly ASXL1, EZH2, IDH1 and 2, and SRSF2, appear to have a worse prognosis in terms of overall survival and risk of leukemia transformation. We're beginning to harness that in highlighting patients that we might wish to take forward in specific trials to personalised medicine. But we're also being able to identify that these patients may well not respond as well to drugs like ruxolitinib. So for example, recently data has come from the MD Anderson showing that patients who have at least one but two or even three of these mutations have a shorter time to treatment failure with ruxolitinib and may not have such a good response. At this ASH, there was more data concerning these mutations, really confirming what's been presented in the last year.